Welcome, everyone, to Redesigning Maternal Health, integrating doulas into care teams. We're so excited for today's webinar. Before we begin our discussion today, I want to go over a little housekeeping. If you need to use closed captions, please enable them by clicking on the lower part of your screen. As well, throughout our discussion today, we encourage you to use the Zoom question and answer function. In addition, at the end of our webinar today, there will be a poll and survey shown. Please complete this. This will be so helpful for us as we identify upcoming maternal health topics. Lastly, anyone who's registered for today will receive a webinar recording, and that will be sent to all the registrants. It'll also be posted to our webpage as well as uploaded to Health Leads YouTube. Health Leads is a nonprofit that works both locally and nationally to remove deep-rooted systemic barriers to health, center power, and resources within communities, and build a world where racial health equity is the standard. Our mission, we partner with communities and health centers to address uses of inequity and disease. We do this by removing barriers to keep people from identifying, assessing, and choosing the resources everyone needs to be healthy. There are 4 strategic levels to our work at Health Leads: shared power and decision-making, community investment and learning, equitable data and measurement, sustainable care, and care worker sustainability. Our work in Boston is a great example of how shared power, decision-making, community investment, and sustainable care are working in action. Today's webinar is a great example of our commitment to learning and how we model and bring folks together across the country. And lastly, thinking about sustainable care and the doula work in particular, doulas are very important to our care workforce. In New York, our New York maternal health team has worked very hard over the last 4 years, in particular in the maternal health space. They worked in partnership with New York City Health Department. This partnership is an extraordinary example of how our collaborative approach at Health Leads brings together unique stakeholders: healthcare institutions, managed care organizations, legislators, and most importantly, doulas. This work has been instrumental in centering the voices of doulas and their priorities. Key accomplishments from this initiative include advocating for reimbursement, pushing for a living wage, and supporting the implementation of the Medicaid benefit. Currently in New York, we're addressing how to integrate doulas into the care team as the next part of this work. I am excited about today's discussion because it's an opportunity for us to leverage all of the learnings across the country. And with that being said, it's my pleasure to introduce Dr. Linda Hudson, Assistant Professor of the Department of Public Health and Community Medicine, Community Engagement Research Unit Lead for the Center for Black Maternal Health and Reproductive Justice at Tufts School of Medicine.
Good afternoon, Stephanie. Excuse me, and thank you for that introduction. I'm Dr. Hudson, and I state with a full heart the critical contribution of the doula workforce to the optimal health and welfare of the birthing population, and it cannot be overstated their level of contribution. Many of the initiatives I am engaged with at the Center for Black Maternal Health and Reproductive Justice at Tufts School of Medicine is focused on lifting up and supporting the best environment, excuse me, for doulas. As many of you may know, the Medicaid program in Massachusetts, MassHealth, recently approved a pathway for doulas to become Medicaid providers. The center has developed a toolkit which will assist doulas in navigating the process successfully, which will be released shortly. And the intent is to assure that we have as many doulas being compensated for the work that they're doing, and that our birthing population will have the people that they want attending to them when they need them most. In addition to the center's work on policy advocacy, including the Momnibus bill recently passed in the state legislature, we do a lot of work on Black maternal mental health, impact of stress, and we also produce an annual symposium for Black maternal health. This year's 8th annual symposium will be centering the role of fathers in addressing maternal health language. In addressing maternal health disparities. So that's enough about me and the center. Before we hear from panelists, let's center on our shared language about the work of doulas for this conversation. A doula is a trained specialist who offers various culturally sensitive services, which may include ongoing physical, emotional, spiritual, and informational support to clients and their families before, during, and after childbirth. As many of you know, doulas help their clients prepare for birth and advocate for their wishes, encourage them to take an active role in their pregnancy journey, and assist them with their transition into parenthood. Although doulas are not medical professionals, they provide critical support to patients in a variety of settings, including hospitals, birth centers, and federally qualified health centers. Evidence is clear that doula-assisted births result in lower healthcare costs, reduced cesarean section rates, decreased maternal anxiety and depression, increased breastfeeding rates, and improve the communication between low-income, racially and ethnically diverse pregnant women and their healthcare providers. Despite all these wonderful outcomes, doulas face several barriers when supporting their patients. These barriers include, but are not limited to, misconception and negative perceptions around their role, lack of education and training for healthcare providers regarding how to integrate this wonderful birth workforce person into the birthing process. There are turf battles, power dynamics, lack of collaboration and communication, negative attitudes and biases. And of course, we are learning so much more about varying Medicaid reimbursement rates and workforce sustainability. It's my pleasure to present to you today's presenters who will share their particular programs and processes and how they address these common barriers in clinical settings. Today's conversation, as most of you know, is timely because last week was World Doula Week, and we will be kicking off Black Maternal Health Week this week. This year's theme, Healing Legacies, Strengthening Black Maternal Health Through Collective Action and Advocacy, undergirds the work and the stories and the experiences we're going to hear today. Today's panelists are examples of how we are working to move the needle to ensure mothers and babies thrive. So with that, I'd like to introduce our first speaker, and that will be Allison Whitney, who is the Assistant Director, Clinical and Community Partnerships at the Center for Health Equity and Community Wellness, the New York City Department of Health and Mental Hygiene.
Thank you so much. Good morning, everyone. My name is Allison Whitney. Thank you for introducing me. I'm from the New York City Department of Health and Mental Hygiene. I'll be presenting today on our Hospital Doula Friendliness Guidebook, which is a compilation of tools, resources, and best practices, as well as lessons learned from implementing a hospital doula friendliness model with our first cohort of maternity hospitals. Next slide. So we know that racial disparities between Black and white birthing people are stark and unacceptable. We also know that evidence shows that doula support has the potential to reduce racial health inequities and birth outcomes for Black and Latino people and increase respectful care during birth. Our team focused on supporting organizational culture change to build anti-racist healthcare systems with the overall goal of increasing access to doula support. Next slide. So what is doula friendliness? The definition provided here was developed by the New York Coalition for Doula Access, co-led by Health Leads and the New York City Department of Health. Doula-friendly institutions consistently demonstrate support of the doula's role in its full scope and integrate doulas into the birthing team. The audience for this resource is hospital staff, doulas, and maternal health partners who are interested in utilizing or adapting the tools and resources found in the guidebook. The goal is to provide guidance on how to collaboratively implement policies and practices that improve collaboration between hospital staff and doulas, and really support integrating doulas into the maternity care team. Next slide. It's important to acknowledge the decades of work community-based doulas have done in New York City maternity hospitals to build relationships, improve policies, educate and collaborate with staff, and advocate for doulas and their clients. Our work is based on and informed by their hard work. I also want to thank and acknowledge all of our clinical partners at our first cohort, hospitals who participated in this intervention and collaboratively implemented doula-friendly policies and practices with our community-based doula program partners into their hospital systems. And lastly, I want to thank all of our clinical and community-based doula partners who reviewed and provided input on the guidebook. Next slide. So we've included a link to the guidebook in the chat. I won't be going through it in its entirety, but I just wanted to highlight a few features. The process map on page 8 lays out the different steps hospitals and doula organizations will move through together. The first step is to engage in a doula-friendly working group with representatives from the hospital and community-based doula organizations who will meet regularly. After identifying key liaisons from both groups, the working group will implement a baseline assessment, develop an action plan after reviewing assessment results to identify actionable steps to take to improve in each of the key capacity areas, implement doula-friendly policies and practices, facilitate and host grand rounds and meet and greets, and establish a referral and reporting protocol. This process closes out with an end-line assessment and a sustainability plan for integrating everything learned from this process. Next slide. Another feature to highlight is our assessment tool. The rubric shown here is an example of the scoring criteria we've laid out for the key capacity area of staff knowledge of doula support. So as you can see, the questions on the left are asked in a facilitated multi-stakeholder group discussion. And then each key capacity area is scored on a scale from basic to moderate to robust with defined criteria for each scoring level. This format is mirrored in the rest of the rubric as well. Next slide. After sharing back the baseline capacity results, the work group of hospital staff and community-based doulas move through an action planning session and complete the template seen here. The results identify the most significant areas for improvement, and participants will identify tangible action steps they can take to move to a more robust level of doula friendliness in each area. Some examples are shown here, like including the doula's name on the whiteboard, purchasing birthing balls, and working with anesthesia to develop a policy that supports doula presence during epidurals. Next slide. Another feature is the Tale of Two Hospitals, a series of case scenarios throughout the guidebook that demonstrate how a doula-friendly hospital can support a better patient experience and outcomes and support doulas in their full scope of practice. In this example, a patient, Jessica, is able to receive support from her doula, Ashley, as soon as she gets to the hospital. In the second tale, at a doula-unfriendly hospital, Ashley is prevented from supporting her client, and Jessica struggles with the pain and ends up getting an epidural. Next slide. And this highlights two features: the incredible photos we have throughout the guidebook and a sample policy that one of our hospitals implemented. The photo captures a doula performing a tug-of-war technique to assist her client through the pushing stage of labor. This photo also demonstrates the portion of the policy that states that hospital staff are responsible for allowing and supporting non-medical comfort techniques for labor. You can see that the providers are stepping back, facilitating comfort measures, and observing. Next slide. We also have some supplementary resources up on our website that include a sample intermittent monitoring policy, the Principles of Doula Support, which is a foundational document developed by NICTA and resource for hospitals, as well as the New York City Standards for Respectful Care at Birth. Next slide. We have many lessons learned in the guidebook, but I just wanted to highlight a couple. Shifting organizational culture can take time and be especially challenging. Some solutions are to implement a pre and post labor culture survey to identify attitudes, beliefs, and perceptions of hospital staff towards doulas. This can measure improvement over time and also identify areas to focus in on that might not be shifting. Another challenge we identified was that high staff turnover and limited capacity, that staff knowledge of doula support could decrease over time. A solution is to develop asynchronous trainings that reflect the Grand Rounds series and require completion of these modules. Next slide. And then I also want to briefly highlight some of our programmatic data from our cohort 1 hospitals. Within each key capacity area, hospitals showed the largest improvement in patient awareness of doula support and implementation of general policies and practices. Hospitals had the highest scores at the baseline and implementation of policies and practices around laboring and doula presence. There was a slight decrease in the laboring policies and practices score. This shift in score occurred at certain hospitals after the team observed challenges achieving consistent implementation of policies into practice. In hospital scores overall, we saw a 33% improvement in scores at the end line. Next slide. And this picture is from our guidebook launch in December in collaboration with the Right to Be Back campaign. We held a panel of clinicians and doulas who spoke about their experiences implementing the guidebook. As we look towards the future, we would like to continue to present on the guidebook and our model at a local and national level. We are also planning to add hospitals to our second cohort with the ultimate goal of expanding to all 38 maternity hospitals in New York City. And we will continue to partner with health leads to co-lead the New York Coalition for Doula Access, supporting implementation of the Medicaid benefit for doula support and workforce development, as well as a hospital doula friendliness designation. Throughout all of this work, we will continue to center and support relationship building between hospital staff and doulas. Thank you so much.
Thank you so much, Allison. We appreciate what you've shared with us thus far. We're going to have a question and answer session at the end of all of our presentations. Next up, we have Stephanie Kennedy, who is the Senior Project Manager for the Louisiana Public Health Institute. Welcome, Stephanie.
Thank you so much, Dr. Hudson. Good morning or afternoon, everyone, depending on where you are. So like Dr. Hudson mentioned, my name is Stephanie Kennedy. I'm the Senior Program Manager at the Louisiana Public Health Institute, and I'm based in New Orleans. I'm also LPHI's Family Health Program Manager. So I'm excited to join the webinar today to share both lessons learned and the planning process of our doula collaboration initiative. And thank you to Health Leads for having me in this space today. So here's an overview of what I'll be sharing today. First, I'll share a little bit about LPHI and its family health portfolio. Then we'll dive into the implementation of our first doula community of practice and how our project team leveraged the doula friendliness guidebook to develop the curriculum and activities for cohort 1. And finally, we'll share where we are in the process of planning our second cohort. And throughout the presentation, we'll share a couple of polls and questions in the chat to give you an opportunity to provide feedback on our process so that we're capturing the voices of the partners on the call today. All right, so just a little bit about LPHI. So we were founded in 1997, and we're a statewide community-focused nonprofit committed to ensuring that all Louisianans have fair and just opportunities to be healthy and well. So we do this a few ways, by authentic partner and community engagement, using data and evaluation and research for action, policy and advocacy, and designing and implementing programs, and offering fiscal and administrative support to community-based organizations. Next slide. So we know that pregnant and postpartum people in Louisiana experience some of the poorest maternal health outcomes in the country. Louisiana ranks worse than most other states on outcomes, such as adequate pregnancy care, preterm birth, maternal morbidity. And over 26% of Louisiana's parishes are considered maternal care deserts, which are areas without access to birthing facilities or maternity care providers. And 16% of pregnant people in Louisiana reported not receiving access to adequate prenatal care. So both of these statistics are higher than the national average. So for over a decade, LPHI has built and expanded its family health portfolio to ensure the well-being of women, children, and families in Louisiana. And this includes increasing access to doula care, which we know improves maternal and infant health outcomes. Next slide. So let's dive into the implementation and outcomes from our first cohort of the community of practice. So before I go any further, let me share a definition for level setting. So a community of practice is a group of people who share a common interest or passion and learn how to do something better by interacting regularly to foster a shared understanding and knowledge base. So the goals of our first cohort of the community of practice were to improve participants' ability to describe how collaboration between doulas and medical providers can improve participants' ability to identify and implement strategies and processes that can improve collaboration between doulas and medical providers. Next slide. So for our first cohort, we recruited hospital and clinic administrators, doulas, clinical providers, and other birth workers from regions 2 and 4 in Louisiana. And we wanted them to share best practices and work together towards building, better collaboration between doulas and other members of care teams, ultimately improving maternal health outcomes. And during the planning phase of cohort 1, LPHI, we're so grateful that we were connected with health leads, and we were able to identify opportunities for alignment and collaboration on our doula initiatives. So it was then that we were introduced to the Doula Friendliness Guidebook and Process Map, which we used to develop our curriculum and implementation activities. Next slide. So the first community of practice consisted of 4 90-minute virtual learning sessions and 4 supplemental coaching calls, so 8 sessions total. And we also had 2 assessments, pre and post, and then also post-session satisfaction surveys that were distributed to participants. And our curriculum incorporated key steps from the Doula Friendliness Process Map, including having session 1 facilitated and led by a doula who works in the field, using session 2 to highlight and help organizations determine policies and practices and collaboratively identify priorities for change, and then identify and planning actions to improve respect for doulas in session 3. And our 4th session was on care coordination. And per guidance from the Doula Friendliness Guidebook, participants were given assessments to gauge their understanding of the roles doulas play in serving pregnant people. So I think we have some polls. We wanted to poll the group today just to see who's in the room, but also get some feedback. All right, so for hospital and clinic staff or anyone who works in administration, how would you rate your current understanding of a doula's role? So from 0 to 4, you can answer that question. And then for our doulas and birth workers, a question for you. What proportion of the medical staff you encounter are familiar with the role of doulas as well as the benefit of doula support? And we'll give it just a couple of seconds for you all to answer. All right. Not sure if I'm seeing the results. There we go. Okay. So and I'm not sure if everyone can see this, but for doula understanding, most people reported that they have, or for hospital and clinic staff, most people reported that they have a complete understanding of a doula's role and benefits. We have a brave soul who said that they don't have any understanding, which hopefully by the end of this webinar and with some resources that we'll share, we can improve that or increase that understanding. And for doulas and birth workers, again, some honest feedback. Some people reported that a lot of the medical staff that they're working with are not familiar with the role of doulas. So some people reported that we have a small percentage, some are falling right there in the middle, and then a smaller percentage are saying that some of their medical staff that they encounter have a higher understanding. So thank you for that feedback. And these are just some examples of the assessment questions that were included in our assessments, our pre and post assessments that we were given to, that we gave to our participants. So also as part of our assessment, hospital staff and doulas were also surveyed pre and post community practice about referral relationships, information sharing agreements, training plans, and permissions to accompany clients during all touch points during and after pregnancy. And the most notable outcome from the assessment was that doulas at the end of the COP showed a 12% improvement of their assessment of hospital staff's understanding of their role. You can go to the next slide. And one more. All right, so additionally, just some qualitative information. The participants shared that they appreciated the opportunity to work through barriers, hear doula perspectives included in the conversation, and appreciated the opportunity to have input on how to better assist their clients. Now I'd like to share more about where LPHI is in planning the second cohort of the doula collaboration community of practice. So for our second cohort of the doula COP, we have very similar goals, with the addition of having tangible products created by the end of the community of practice. So throughout the second cohort, facilitators will lead skills building activities and assignments that will guide participants through the process of developing collaboration agreements, information sharing agreements, and referral relationships, which will be measured at the end of the community of practice implementation, along with any associated trainings for staff. And in this second cohort, we've expanded recruitment efforts to include all client-facing staff in clinics and hospital systems, community health workers, and birthing people and families. So this is the most important thing that I want to highlight. But from an equity perspective, we know that including the voices of the people who are most impacted, so the people who are giving birth and the families, by including them in the policies, procedures, and agreements, or developing those policies, procedures, and agreements, we know that that's a best practice from an equity perspective. And in this cohort, we have more of a rural focus. So we want to prioritize recruitment from regions 4, 5, and 6 in Louisiana. And to ensure that we are elevating the voices of the individuals and organizations who are doing the work and those with lived experience throughout our process, we engaged a steering committee of maternal health partners from across South Louisiana to guide planning, including further curriculum adaptation and participant recruitment and subject matter expert recommendations to facilitate learning sessions and coaching calls. And then here are a few things that have come up for consideration during the planning for the second cohort. So this is some feedback that we got. Oh, I see we have a question. Okay, yeah, we don't have to answer this one right now, but we'll probably drop it in the chat. So what ways have you previously engaged those with lived experience in project planning and implementation? And what strategies have made engagement successful? So you don't have to answer it now, but you can answer it in the chat or in the Q&A section, and then we'll capture those results. And again, we're giving you all an opportunity to have your voices heard as we're in real time of the planning for our second cohort. So if you'd like to share any strategies, that would be great. So again, these are a few things that have come up for consideration during the planning of cohort 2, and mainly from our steering committee and the feedback that they've given us. So the first thing is we discussed when and how people with lived experience are included in the community of practice. So you'll see in a later slide that we do plan to launch our COP, our kickoff, by sharing some lived experience. So having someone come in and talk about what it was like to give birth with or without the support of a doula. But the question came up is when and how will people with lived experience be included in the community of practice? Are they there only to share their experience, or will they be included in the process of developing policies and workflows that improve doula collaboration? So again, from an equity perspective, we know that including those voices in the policy development is a best practice. And then the idea of integration. So I know that is the topic for today. And that was the original title of our community of practice. It was the Doula Integration Community of Practice. But the question came up, what does integration look like? And is integration actually the goal? So from the feedback that we got, the perception of our doula community is that integration implies that the end goal of our work includes doulas working for and within hospital systems, which in some cases can take away the autonomy of doulas who could be forced to operate within the guidelines of existing hospital policies that have proven to not support friendly, respectful, and collaborative environments. So instead, the focus should be maintenance of and collaboration between our strong network of community-based doulas and other care providers. So just a little bit about our curriculum, and I dived into it just a little bit in the earlier slide. But we used the curriculum that was developed during cohort 1 and adapted using the feedback from the steering committee to tailor the cohort curriculum to the current needs of doulas and providers. So the biggest changes are that we plan to launch our community of practice, again, with lived experience from impacted individuals and families, and include them in our policy and workflow change processes. We also plan to allow doulas, providers, and advocates to facilitate the sessions as subject matter experts in the field instead of LPHI facilitating all of the sessions. We also plan to incorporate more training and technical assistance around policy development in the community of practice, as the goal is to develop institutional agreements that support collaboration. And again, we shifted titles. So based on the feedback from the steering committee, we have shifted from using the word integration to collaboration. And these are our next steps in the planning. Oh, we have another question. All right, so what else needs to be captured in the evaluation of this project? Or what else would you want to know from our participants? And again, we can save this question for the end, so you can provide your feedback at any time and that'll get back to me. But we can move on to next steps. All right, so these are the next steps in the planning and implementation phase as we plan to launch our second cohort of the doula collaboration community of practice in May. So next month we'll be launching. So LPHI will continue to engage our steering committee and other maternal health partners to identify subject matter experts for facilitation and potential participants. We'll also use the feedback from our steering committee and feedback you've shared today to finalize our pre and post assessments to measure changes in understanding of doula roles, as well as the number of policies developed or changed as a result of the community of practice. Our hope is that we can use lessons learned and build upon the success of cohort 1, as well as leverage relationships with our national partners like Health Leads and our local partners to improve maternal health in Louisiana. And then I just want to give a special thanks and acknowledgments to our steering committee, as well as our funders. So thank you to the Packard and the Blue Cross Blue Shield of Louisiana Foundations for funding us to do this work. And then also acknowledgments to our implementation team, so myself, Reagan, and Mignon. I hope they're on the call to see their acknowledgement. And as you can see in real time, we're still making some changes, so our titles have to be changed as well. So again, we're making that shift from integration to collaboration. But thank you to our steering committee, thank you to the implementation team, and thank you to Health Leads for having us today.
Thank you very much, Stephanie, for your presentation and for the information that you're bringing, and specifically the engagement of those who are impacted being critical partners in the work that you're doing. So next we have Alicia Larson and Jeanette Myrick. Alicia is an assistant professor in obstetrics, gynecology, and reproductive biology at Harvard Medical School, and Jeanette is a doula and perinatal health researcher at Beth Israel Deaconess Medical Center. Thank you, ladies, for joining us. The floor is yours.
Great. Thank you, Dr. Hudson, and thank you to the Health Leads team for having us. We're excited to share our experiences at Beth Israel Deaconess Medical Center, which is a hospital in Boston. Next slide. I will start off by giving you some information about our local context, and then Jeanette and I will delve right into doula integration. We've used that word here for quality improvement. Next slide. We are based in Massachusetts. Mass Health is the Massachusetts Medicaid and CHIP program, and since late 2023, all Mass Health members have been eligible to receive doula services as a covered benefit from pregnancy through 12 months postpartum. And doulas are considered part of the care team. I think it's important to note that at our hospital and at many hospitals, the end goal is, as Stephanie was saying, not to have doulas working for the hospital system, but rather to be collaborating authentically and appropriately with doulas. We acknowledge that we have doulas interacting with our system in many different ways. We do have some doulas that are employed directly by one of our health centers. We have many doulas who are paid through a third party, and then many community-based doulas who are being paid directly by the pregnant person. Next slide, please. When we started our work, we did a survey with obstetricians, anesthesiologists, and nurses who support labor and delivery at Beth Israel. And we found that the value of doulas was not consistently appreciated. So only 47% of the over 100 respondents felt that doulas were an important part of the maternity care teams. When we asked them what their first reaction was when they saw that a doula was supporting a birth, they ranged dramatically. So some folks said something along the lines of, great, someone to help support the patient in their labor. Somebody else responded, I hope that the doula and my approach to care are compatible. And another person said, I often dread taking care of patients that have doulas. We know that we're not alone with this. The next slide gives you two links that I think will also drop in the chat for two other publications who really looked deeply at both. The one on the left there is looking at clinician perceptions of doulas, and the one on the right is talking about this implementing community-based doula support in the hospital. And they have some similar findings to what we were finding in that baseline survey. Next slide. So given this, we wanted to ask, this was back in 2022, how can hospitals work with doulas in a way that optimizes health, improves experiences, reduces costs, and supports workforce well-being? Next slide. Because I am an implementation scientist, I turned to implementation science. This is a field of methods that really says, okay, we have an effective intervention, in this case, doulas, but it's not necessarily being implemented effectively in all places. How do we get from this intervention to the outcomes that we want? And so one way that we can do that is through implementation mapping. And we've written out these 5 steps to implementation mapping for you here, and I'll walk you through, and Jeanette will walk you through what we actually did at Beth Israel. Next slide. So our first step was really identifying implementers and implementation needs. So we started what we call the Supportive Birth Collaborative. We centered the patient, and so we had patients on this group. We brought together obstetricians, anesthesiologists, nurses, doulas, social workers, and researchers to join the patients. Next slide, or click ahead. We started off by defining our overall goal of this group, and we decided that our goal was to identify, implement, and test interventions that aim to integrate doulas into the labor and delivery unit. And by integrate, we didn't mean a full integration where doulas are paid, but more that there was a collaboration, strengthen the relationship between clinicians and doulas, and thus improve patient experiences and maternal outcomes. To this end, you can go to the next slide. We needed to come together and figure out, if this was our goal, how are we going to get there? And so we went through a process where we were all on Zoom, and we put up on the Jamboard what you see on the right in gray, yellow, and green. So the long-term outcomes, ultimate goals, and equity and care and outcomes. And we started from that and said, if we can all agree that this is where we're trying to get to, and we've got doulas over here on the left, how are we going to make this happen? And I facilitated, as a researcher and not a clinician, not a doula, I facilitated this conversation amongst all of the other stakeholders that you saw on the previous slide, and they came up with these specific short-term outcomes that they wanted to get to. You'll see many of those in the previous talks by Allison and Stephanie. And then they picked out these activities that were relevant to getting us there at the BI. We decided that these activities largely fell into 2 different groups, and so we created an education subgroup and a policy subgroup. Next slide.
So that brings us to step 3, designing implementation strategies. So as the SBC explored approaches for our hospital, we turned to the ERIC framework, which is a structured guide for driving effective change in healthcare settings. Next slide, please. So on the right, we have 10 practical applications that align with the theoretical implementation strategies from the ERIC framework. And our team really focused on strategies that were inclusive and could be standardized for all doulas. Next slide. And that's when we got to work and began tackling the activities. Much of the work was done in smaller working groups. So for instance, we introduced doula-specific name badges, making it easier for hospital staff to identify the doula in the room and recognize their role in the patient's care. We also updated the EMR to ask whether patients have a doula. And this wasn't just about documentation, it was also meant to encourage patients to reach out to their doula. Because what we found is that some patients were hesitant or forgot to call their doula, especially if it's in the middle of the night or in the heat of the moment. So this provided an opportunity for staff to give a gentle nudge and say like, hey, you're in labor and I see you have a doula. Have you been in touch with them? The last thing we did is we made it common practice to record the doula's name on the whiteboard in patient rooms. And this small change helped doulas be part of the care team, reinforcing their presence as part of the patient support system. Next slide, please. So we then got to work on relationship building between clinicians and doulas. Community doulas were invited to present at faculty grand rounds and resident didactics. We also organized nurse-doula co-education events. For example, we had doulas set up a Ask Me Anything table on the L&D floor for on-service nurses. We also incorporated a doula into the annual medical student simulations, so trainees could interact with a doula and see firsthand how doulas support their patients in a clinical setting. Next slide, please. So we also updated the hospital's doula policies to foster collaborative support in L&D. The document on the left outlines the doula's role in the labor room for hospital staff. It also clarifies that doulas are not included in the support person limit and may be present in the operating room at the anesthesiologist's discretion. The document on the right provides guidance for both patients and clinicians on including doulas in the OR, reinforcing that doula support doesn't end at the OR doors and remains just as valuable during cesarean deliveries. Next slide, please. So the next step was to evaluate the implementation outcomes to assess whether the changes we were making were actually having an impact. And to do this, we conducted a structured survey with clinicians both before implementation and again 1 year later. So we found significant improvements in clinician trust in doulas and in communication between clinicians and doulas. We also saw a modest increase in clinician trust in care teams that included doulas, as well as a slightly better understanding of the doula's role. However, neither of these increases was statistically significant. Next slide, please. So through this process, we've identified several ongoing challenges that still need to be addressed. First, there are still institutional and cultural barriers, such as resistance to non-medical support in clinical settings and varied adherence to policies on doula presence. So this has made it difficult to fully collaborate with doulas in our hospital environment. Additionally, many clinicians still have a limited understanding of a doula's role, which affects how well doulas are included in care teams. To bridge this gap, we recognize that there's a need for more interactive, hands-on education because that's what typically sticks. So one way we're addressing this is by including doulas in simulations for our more experienced clinicians, ensuring that even seasoned staff gain firsthand experience working alongside doulas. And additionally, we're expanding our simulations to include a co-ed component, which allows trainee doulas and clinicians to practice together in high-risk scenarios. Lastly, we did not gather feedback from the doulas and patients during this first iteration, but we plan to incorporate this in the next phase so we can ensure that we're meeting their needs as well. Next slide, please.
So thinking forward, in the next step is, sorry, I'm just going to quickly go back to what Jeanette just said. We did get doula and patient feedback as part of the collaborative, but she means quantitatively, we have not gotten that, that feedback yet, and that'll be the next step. This is meant to be a summary, for folks who are thinking about asking these questions next and how they might put together this group. It's a little bit responsive to what Stephanie was asking. And we really encourage you when you're embarking on this to think about who the experts are and are they able to share their knowledge and contributions to decision making. It was really important to us that those experts were all at the table and that they had opportunities both in the group share and then individually with Jeanette and myself to share their thoughts. We asked and encourage others to ask, why is there a practice gap? What are the facilitators and barriers that are specific to your institution? And again, thinking about those implementation strategies, how can you test them? Which ones should you use? And then finally, thinking about the outcomes of implementations. Are they acceptable? Who is implementation reaching? And is it equitable? Next slide. The last slide is just an acknowledgement, just saying that this is a huge team that's putting all of this work together, and that we appreciate all of our patients, our SBC members, and our research participants for their support in this work.
Thank you so much. We appreciate the work that you are doing at Beth Israel Deaconess. I'm right here in Boston. And so we appreciate being able to see the work that you're doing and to know that this kind of process is taking place, can be emulated. And perhaps some of our participants today, some of those who are attending, will be asking you specific questions around implementation. So now we are opening up our question and answer period. And one of the things I'd like to do is first to thank those of you who had sent in questions ahead of time at the time of registration. I'd like to move back and forth between the questions that are being posed right here, right now, on the question and answer chat by beginning with a question that was sent in earlier in terms of the work that you're doing. So this question speaks to beginning with the end in mind. And any one of you can answer this. And that is, what steps are you taking to make your work sustainable? Those of us who are working in the field are always considering the creativity process, the research process. I'm involved in community engaged research. We always have to look for funding. But the key issue becomes, particularly with community and academic partnerships, how does one retain the work that you're doing, and how do you continue to make your work sustainable? Please unmute yourself and answer as you desire.
I can jump in really quickly. As we're working with our second cohort of hospitals, we've actually started to touch base again with our first cohort as we realized that, some of their referrals were starting to peter out, and they had new staff. So we've been meeting with them quarterly as a way to kind of re-engage, see how things are going, and kind of establish those touch points again between the hospitals and the community-based doula programs. But I also wanted to highlight kind of a model that my colleague Nicole Jean-Baptiste has created with one of our participating hospitals that I think is a great example of what a sustainable relationship will really look like, that it's one that exists between the hospital and the community-based doula program directly. So I'll turn it over to you, Nicole.
Thank you, Allison. Hi, everyone. Thank you for this wonderful webinar. So informative and just really, really inspiring for myself, and I hope other folks as well. I am the co-founder of BX Rebirth and Progress Collective here in the Bronx, New York. And one of the really amazing things that we've been able to do over the last 3 years is work closely with Lincoln Hospital, which is a hospital local to us. And we've employed a model that is less traditional than your doula model that most folks know, wherein we are dispatching doulas. We started with 1 day a week, and now we're at 2 days a week to work a 12-hour shift. And the idea here is that we'd meet our people, our community where they're at. What we were seeing was that a lot of folks were coming to the hospital to give birth, either without a partner or without the information and necessary education to navigate a environment like that. And so what we've been able to do in addition to dispatching our doulas is build a partnership with both nursing leadership and OB leadership at that hospital. And we found this to be a really critical element of what we have typically been referring to as doula integration. But I'm really inspired by Jeanette and Alicia and Stephanie, your approach to this as doula collaboration. And what we're seeing is that in order to maintain these partnerships, we're having to meet people where they are and really embrace our humanity. We are doulas. We have a very different, a more holistic, and clearly in a less medicated approach to supporting our folks, right? And in that, we are both experiencing or encountering harm, right? And it's really critical that we acknowledge this at every step of the way and interact with folks with grace and acknowledge that both of the challenges that we face are not easy. And some of the ways that we do that is encouraging, like you said, simulations where doulas are present, having regular meetings where doulas have the opportunity to interface with nursing staff and OB staff in an attempt to really bridge that gap outside of the actual challenging moment.
Thank you so much, Nicole. As a person born and raised in the Bronx, yes, shout out to the Bronx.
Oh, I knew there was some connection there, Linda.
So there's one more question I want to bring, and then we're going to go to the question and answer. And so a practical question is, all of you have worked very diligently, rigorously, using scientific methods to create either a guidebook, a program, or a process that integrates and provides a collaboration between the doula and the rest of the birthing team. One of the questions that came out from our earlier registrars was, how do you in real time deal with conflict resolution at the time that the birthing process is taking place? All that you're doing is wonderful in creating an environment and an institutional attitude that will support the role of doulas in the workforce at the hospitals. But what happens? What do you put into place so that when doulas are kept out of the birthing room or considered visitors, and when the visitor total has been reached, that doula cannot be admitted because there's someone else there? What kinds of things are you using right now to do that kind of on-site strategizing and conflict resolution? Anyone can answer.
So I'll share, and I just want to acknowledge that or the work that LPHI does is not directly in those settings where people are giving birth, but we are working with doulas, birth workers, and then hospital administrative staff and clinical providers to create those policies and workflows and procedures that support welcoming and friendly environments. But what I will say in the second cohort that we're planning right now, in addition to some additional technical assistance in writing policies and procedures, we also want to incorporate some role plays. So I know someone mentioned simulations with doulas, but what happens even in, like, what does it look like when a clinical provider refers a client or a patient to a doula? What does it look like when there are barriers that someone is facing? So we want to prepare people for those situations. So again, for facilitation, we're bringing in subject matter experts, we're bringing in doulas, we're bringing in providers, bringing in advocates to facilitate that conversation and doing some role plays with the participants that are in our community of practice. So we just want to equip people with the skills, the tools, the language, and the ability to advocate for themselves in those situations. So that's our plan for the second cohort, and we're hoping that we have some good outcomes from that.
Thank you so much, Stephanie. Would any of our other panelists like to address the issue?
We have a text chain going with the hospital's nurse manager, the nurse educator, our clinical liaison, who's a midwife on our team, and myself. And this is a way that in the moment we're able to elevate challenges so that they can be resolved in as quick and efficient of a way as possible. And for ones that are not as pressing, that are not as emergent, we have a survey that we ask all staff and doulas to complete to reflect on the experience of working in a setting where a doula was there to support the birth as well.
Excellent, excellent. Anyone else? Well, now let's go to those questions that have been placed in the Q&A. So the first one is, can you all speak to community doula workforce impact and how to get certification in both birth and community doula roles in health shortage areas? And again, thank you, Nicole. Can you all speak to community doula workforce impact and how to get certification in both birth and community doula roles in health shortage areas? Anyone like to answer that? All right. One of the things that we're going to be doing, I'm sure Stephanie mentioned it ahead of time, Stephanie Campbell from Health Leads, is that we are going to be compiling these questions and sending them out along with the PowerPoints, so that as you're being thoughtful about the answer to this question, you'll have an opportunity to answer it, and then those answers will be sent back out to our participants. So don't worry, we are not going to leave any question unattended. So another question we have is, does the Medicaid funding changes affect doula funding? In our current political environment, every day we are thinking about what are going to be the next steps and how are we being impacted. As a public health practitioner, of course, I'm grieving the loss of perhaps 20,000 health and human service workers. But now there's a lot of concern, clearly, about Medicaid funding. So the question to our panelists is, does the Medicaid funding change affect doula funding, given that some states are losing funds for doulas as a result of cuts in Medicaid? Are any of you aware or anticipating what that might mean? Any thoughts on the issue?
I would only imagine that this is going to affect doula's ability to be reimbursed by Medicaid. This is such a new, well, in New York, this is a relatively new just step forward for us. And to see the cuts to Medicaid happening right now, we are in a space where we're wondering whether this is going to be continued. As far as I know, we haven't been notified that this is going to be reversed in any way. But this is something that I think, as a member of the doula community, we do need to prepare for.
Very good. Thank you, Nicole. Anyone else?
Yeah, I just wanted to echo what Nicole said, that, I mean, we haven't heard anything in Louisiana just yet, that our reimbursements for doulas will be impacted. But I'm at the point where I'm expecting anything to happen, and we're preparing for anything. I will say that LPHI has a robust, right now, I'll say still in development, but also very robust for the place that we're in, policy and advocacy agenda. And I'm saying it's still developing because we're responsive to what the needs are at the current time in the current political environment. But I will say that, again, our policy manager and team is very responsive to what's going on at the state level, also very responsive to what's going on at the federal level as well. So we are prepared to work within our organization and with partners who are advocates in the space to respond to any potential cuts that might impact doula access to doula services. So we're ready, expecting anything at this point.
Very good. Thank you, Stephanie.
I want to add on the Massachusetts end of things. We haven't necessarily heard anything either. More recently, we had a listening session that was led by the folks that run the Mass Health reimbursement here in Massachusetts. But other than that, we have not heard anything about any cuts.
Very good. Thank you. I'm going to jump to a few of the questions in the chat, in the question and answer chat as well. There's one specifically for Jeanette and Alicia. How difficult was it to have hospitals commit to allowing doulas into the delivery birthing space where they didn't have to choose between significant others and their doulas? That's pretty much the question I was just asking earlier. So how did you all manage that at Beth Israel Deaconess?
That was actually one of the easier things to overcome, having doulas be in the birthing space. We currently don't have a restriction on the number of individuals that are allowed to support births, but we did during COVID. And so we wanted to make sure that this was in the policy so that if there were restrictions in the future, doulas wouldn't be counted against that. And this space was, the culture had already moved in this direction, and folks were quite supportive.
Very good.
Of this, yeah.
Very good. Now, there's a question here from Malika James. Have there been efforts to integrate communication systems that allow doulas, providers, and other care team members to connect and collaborate effectively? I think this actually, Nicole, you answered that in terms of what you have in terms of your real-time thread that's taking place for conflict resolution. Is there anyone else here that would like to share an example of what you're doing in terms of integrating your communication systems to support and facilitate clear and effective communication? Anyone else?
We actually have, this is a brand new conversation, and so we don't have results on it, but a conversation around, similar to how we do surgical timeouts for safety purposes, doing timeouts to make sure that the care team is in full understanding of what is happening with the patient at the center of that. So it's very common in obstetric care and labor and delivery to have huddles. And so figuring out a way to make that systematic and in a way that has scripted language for the clinical care team to bring the doula into that huddle in a way that allows for not just doulas who regularly support births at our hospital, but so that we're prepared for a doula who's a community-based doula, who this might be her 200th birth, but first one at our hospital. So more to come on that.
Very good. Thank you. I think we've covered the questions that were in the question and answer chat. Please feel free, those of you who are participating in this process, if you have a question, please put it up there. We want to be able to respond to any questions you have available. So in the meantime, I'm going to ask a question. One of the things that we all do, and I so much appreciate, Stephanie, your emphasizing and highlighting and uplifting the need to involve people who are impacted in the work that we're doing around our toolkit. We've recruited community advisory board members who are active doulas, parent advocates, those who are working in both hospital-based situations, those who are working to build a neighborhood birth center in Boston. So we very much recognize that having birthing people, their support systems, a part of the process is extremely important. As a public health practitioner, one of the things I've learned is that people who are impacted generally know the answers. People just don't stop to ask them. They know what the answers are for their lifestyle. They also know what the assets are for their environment. And so I'm so pleased to hear from all of you how you're looking at the positive aspects of the kinds of things that are taking place. My question goes to, how do we work with multiple stakeholders in terms of navigating the power dynamics and amplifying the voice of doulas? What have been some of your best practices in terms of engaging, compelling, recruiting those multiple stakeholders to join you in this endeavor?
I can start to answer this one. In the early days of our work as part of the Maternity Hospital Quality Improvement Network, we were, starting our work with about 3 hospitals before we expanded to all 7. And we partnered with many of the community-based doula organizations that we do now, but we weren't paying them. And I think that such an essential part of this work is, whether it's coming from the health department or for the hospital, there needs to be funding in place for doula organizations, because they're the ones who are doing the work. They're providing the grand rounds. They're, providing technical assistance at the meetings. They're going through conflict resolution. We have like emails going back and forth sometimes when an incident arrives, and the person who's addressing it are the doula organizations that we work with. And, that's the overall goal of our work, is to really facilitate that relationship building. But those contracts, having funding in place, is so essential to support the process. So I would say that's definitely the number one way we kind of want to center doulas in this work, as the health department, because we do have the means and the support and resources to do that.
Very good. Thank you so much, Allison. Anyone else? How do you deal with multiple stakeholders and compel them to participate in this process?
So I'll echo what Allison said. So 2 things. I'll highlight partnerships and collaborations first. So having the partnerships with the folks that we have on the steering committee, who again are a range. They fall along a continuum. So we have medical providers, we have doulas, we have doula trainers, midwives, people who own doula organizations, all on the steering committee. And having those strong partnerships with people who are entrenched in the work is helpful in recruitment. So someone might not know Stephanie Kennedy from New Orleans, but they might know Victoria Williams from Birthmark Doulas in New Orleans, as the person who leads that organization and is the advocacy lead for the organization. So having relationships with the people who are boots on the ground doing the work, who are advocating for birthing people on a daily basis, are paramount, I think. So having those partnerships and collaborations. But then also, again, to Allison's point, compensation. So recognizing that everyone's time and expertise is valuable. Whether you are a medical provider, doula, birth worker, community health worker, lactation specialist, again, along this continuum, everyone deserves to be compensated. And I understand that funding is not always readily available, but in cases where there is funding, prioritize compensating people for their time, their talent, and their expertise is also a priority as well. So both our steering committee members, the people who participate in the community of practice, and the expert facilitators will be compensated for their time and talent.
Wonderful. Thank you. Alicia, you unmuted yourself.
Yeah, I was just going to add, I completely
Awesome.
echo the relationship, the compensation, we do that. I think the other thing that's really helpful for getting people to stay in this work is giving feedback. So saying what you've actually done, reporting back. I think in the research world, we are very bad at taking everybody's information and then just running with it and not providing that feedback. And so making a really big effort to go back to those people who are working with you and let them know what's happened and what's changed and where the future problems are, I think really helps people to stay engaged.
And one more thing I want to add to that. One thing
Yesterday.
we do often is we step back and allow we encourage our patient voices to really lead conversations and to take over and say what is most important to you. You make the final call and we'll go with what you want. And so definitely, and is compensated. That is compensated as well. So definitely centering their voice and what they want has been important.
Very good. I don't see any additional questions here. I do have one, and that has to do, as you're working with your doula population, do you find that there's any distinction or difference based upon certification? It's an issue that we take a look at here in Massachusetts around the work that we're doing. There's such a thing as the experience pathway in terms of doula engagement, and then you have those that are certification process that takes place. Do you find that there are any distinctions in either how you approach or the needs of these different populations? If at all, there may not be any differences in your particular states. For those of you who may have joined later, we have representation from a program in New York, from a program in Louisiana, and from a program here in the Boston area. So can you share any issues that come up regarding certification, non-certification, experience pathway? Do any of these things influence how doulas are appreciated and welcomed?
I would say it's been one of the biggest barriers that we've encountered with the hospitals. I think we've seen a slight decrease in hospitals not allowing doulas in due to proof of certification. And I'm hopeful that the Medicaid benefit has been helpful with that since they do not require certification of doulas. But I think a lot of it comes from a misunderstanding or, just a lack of education around what doula support is. I think there's sometimes a perception among clinicians that they are licensed, they have, that's kind of how their world is centered around licensure and certification. And the fact that doulas aren't required to have certification, I think is kind of hard for some providers to understand. But yeah, just speaking from, our work, I think I have never noticed a difference in kind of the level of expertise or experience or services provided between a certified or a doula who doesn't have certification, but it has been an extreme barrier at the hospitals. Some hospitals still have a policy in place that requires proof of certification or at the very least proof of training. And we've identified that in our work with hospitals as a huge barrier. One that we ask that, instead of requiring certification, can we look at, ensuring that doulas have IDs or wristbands? So there are alternatives to that that aren't so limiting and won't essentially prevent a doula from being able to attend her client's birth.
Yeah, I'd have to agree with Allison. I one silver lining though is that this has been being such a focal point. It's created a pathway to the process of unlearning for a lot of folks who are not familiar with what doulas do and have this assumption, this expectation that, again, you are regulated in some way or you must be licensed in order to practice. And then this just leads to really the history and the depth of doula work and what our true essence is, and that this is not a field of work that that requires certification necessarily. So it has definitely been a barrier, and it's been a pathway to learning and education around what it is doulas do.
Excellent. Thank you so much. Well, I think we're at the time now where I'm going to be turning, first of all, I want to thank you all for your sharing of your experiences, for the diligent and rigorous work that you've been doing and that you're going to continue to do. We thank you for your learned responses to the questions that have been asked. As I mentioned earlier, all of the questions that are in the chat, that are in the Q&A chat, will be sent out so that you'll have a chance to think about it and respond to it. I'm particularly appreciative on behalf of the Center for Black Maternal Health and Reproductive Justice here at Tufts University of hearing about the guidebooks, to hearing about the communities of practice. We were very familiar with the work that's taking place at Beth Israel Deaconess, as several of the members of the board that was working there actually work with the center. But for all of us to be able to see the different bodies of work, the scope of work, and the rigor that you're bringing to this process, it's just motivating. At the same time, this is where science meets real life. And what I'm saying is what you all have brought together is that intersection of rigor and science and the value and validity of the real experience meeting together to ensure that we have better birth outcomes, particularly for our marginalized and vulnerable populations. So now we are at 1:11. And I'm assuming that I'm going to be turning this back over to Stephanie Campbell. Those of you who've registered, you know that you're going to be getting a lot of this information from the organizing committee moving forward. So Stephanie, the floor is yours. And I appreciate the opportunity for inviting me to participate in this process.
First of all, thank you all. You all were phenomenal. Dr. Hudson, Nicole, nice to meet you. Thank you for joining as well. Jeanette, Elisa, Stephanie, you all were just amazing. And a few things I want to point out. There were so many gems shared today, and really consider this the first conversation that we're going to host. And I think today's webinar is really a reminder in real time the approach that Health Leads plans to take around maternal health. We recognize it's a complex topic and we need collaboration. Collaboration nationally. We know that we're all navigating uncertain times in many ways, from funding to workforce, et cetera. There's so many perspectives that are needed to really begin to improve maternal health outcomes. With that being said, I really appreciate today too, just the intentionality of language. Is integration the best word for the goals? Whose voices were missing? I'm sitting here with so many questions, and I really look forward to continuing this work with you all. So a few housekeeping things just to wrap us up. One, you will get the recording and the slides. Also, please do the poll that popped up on your screens for those of you who are still with us, as well as please do the evaluation. That's important. Also, this upcoming Friday is the Center for Black Maternal Health Conference. I saw in the chat the registration was open back up specifically for this group. Do not miss out on that important information. That's a virtual conference. Registration will be reopened for us, for those of you who want to join us this Friday with that. Last thought that I have before I let you all skedaddle virtually, if there are other ways you would love to partner with us on this topic, please reach out. We are very much interested in amplifying current learnings. There's no need for any of us to reinvent the wheel because you all have already laid such strong foundation nationally around how to best work with doulas, how to bring birthing people into the conversations. And again, I just want to thank you all for your time, your energy, your patience, your commitment to this work. And I look forward to being in partnership with you all.